Oh, hey, Asantewaa, how are you doing?
I'm good. How are you, Karen?
I'm good. I'm so excited that we're having this conversation today. First of all, it's super duper timely. But before I even get that far, we've just met. We met because we were on a panel together. I knew of your work, but had never, met you prior. And I want you to tell our listeners, what is it that you do? Especially what are you doing in Oakland?
Well, I'm a nurse by profession. I currently work at UC Davis Medical Center in the emergency room, which is located in Sacramento. I'm actually in SAC. But what we're doing here in Sacramento and in Oakland is the Anti-Police Terror Project, an organization that I'm co-founder of, for some time has been combating police terrorism. And we began to take notice of a pattern that folks who were in the midst of a mental health crisis were more likely to be harmed by police, right? And specifically the narrative, right, that we kept hearing case after case after case. It was either substance use or mental health, right, issue, and then person was subsequently harmed by law enforcement. So we were doing the work already in a capacity that was unofficial. And what we decided to do was do the work in a capacity that was official and available to the larger public. And that's where we created Mental Health First. And within our Sacramento chapter, less than a year later, that was replicated in Oakland, California, and has been active in Sacramento for 2 years and a little bit over a year and a half in Oakland.
Wow. So one of the questions I have is starting with this idea of policing and anti-terrorism. So that already existed, but it existed separate from the mental health space. It was just existing as a response to police response to communities. Is that basically it? And primarily communities of color, I'm guessing, right? Okay. And so when you all started doing the work that was more intentional related to mental health and police response to mental health emergencies, how was that received by folks? Like, was everybody, yeah, we're doing this. This is right. Get the police out of this situation. More Black or brown folks are being harmed. Like, tell me a little bit about kind of how kind of folks received what it is that you're doing.
As part of the larger like abolition conversation, right? There's this question of if not the police, then who? And when we think about the different sectors that police exist in, mental health is one of those sectors, right? Police exist in our schools, they exist in hospitals now. You got air marshals, you got, right? Like they're entrenched in most of our systems, right? So when we take a look at, okay, where do the police exist? Where can they not exist? They can definitely not exist in this mental health space. In fact, what we found is that they tend to cause harm when they're in that space. And I have seen firsthand how many times when we come against someone who is possibly not in our shared reality, a lot of the times their thought processes, fears, paranoia, whatever term we're using, right, to encompass that, is around those authoritarian figures. So in fact, not only are they causing physical harm, but even more psychological trauma. Just imagine if you're in a situation and your worst fear is in fact confirmed, and an officer shows up to haul you away to some place where you have like no rights. What they do in that space is show up and determine if someone is 5150able or not, meaning that they can be forcibly hospitalized, and then transport them to a facility that would maintain that status.
So, and this, of course, when you talk about this, I always get like the little goosebumps because of, my own personal experience and interaction initially with the police, and having no idea that when I was struggling and I was told, well, we're going to have to call somebody to help you. We're going to have to dial 911. In my head, what I heard was, oh, you're dialing 911 because I've come to understand from the public view and even the providers, a mental health condition is like any other physical health condition. So when I hear that I'm in a medical emergency caused by psychological distress, I think an ambulance is coming. And that's not what showed up.
Not what happened.
And right. And so my expectation was sort of dashed to begin with. And then when the police were at my door, I was kind of like, I'm a Black person in an all white building, and the police were at my door, saying welfare check. And talking really loudly and saying they're the police. And I have visions of kind of, police with dogs from the 1960s, because I'm a
Oh,
1960s
man.
baby. And it all didn't work for me in my head. And it didn't work for me in my own psychological state either. So
Mhm.
as you say, you just articulated it really beautifully. And I don't know that many folks think of it this way, that, it's feeding into possibly the fears and experiences people are already having that then
Mhm.
get exacerbated if they have a cultural or a LGBTQ lens with all of this stuff as well. So it just takes
Mhm.
it from having distress to adding more trauma to this distress somebody's already having. And then, no autonomy in the situation. You can't get out of it. It's just this like multiple cumulative mess. I will put it that way. So I didn't actually know that this has been going on as long as it has been, in the work that you're doing in Sacramento and then to Oakland. Why hasn't the mental health movement itself why don't we know more about this? Just saying.
We have a lot of work to do divorcing danger from mental health. I think that inadvertently the two kind of exist in the same space. And I think that perhaps the reason why there's not as many folks, right? Because there's been a great response from folks all over the place who are wanting to do similar work, especially with things like 988 on the table, with things like Cahoots Act on the table, right? So folks are gaining interest. And then also there's funding that has come down the pipe that are going to help build the structure for these things. So there are folks, but I think anytime I have a conversation with someone, the first thing they want to know is the danger piece. And I'm like, I've been a psych nurse for
Mm-hmm.
God knows how long, been in the streets in the capacity of like a street medic during protests, mental health first, protesting myself. Like the most danger I have ever been in responding to someone is when an officer was close by.
Wow.
Because they were perpetuating, right, the violence. So I can't say that loud enough. Folks are
Mm-hmm.
the danger, the danger, the danger. And statistically, even looking at a program like Cahoots, who has had to call the police very little. We've never had to call the police. They've had few injuries. We've had none, right? When it comes to like being in actual dangerous situations. The reason why the police, when they respond, have violence is because they are the perpetuators of that violence. And that's a conversation that needs to be had. That
Wow.
it's not the patient that causes it, that it's
Yeah.
the police response that perpetuates it.
And I think this is so powerful because I think when, people with lived experience say the very same thing, I don't want to say that it's ignored, but it's harder to kind of wrap your head around and then do something about it. But when somebody and I'm just going to put it this way, whether people agree with it or not, I'm just going to say it. When you have a psych nurse, an ER psych nurse say, hey, danger happens when the police show up. And I've been in the ER where you see all sorts of stuff in the ER. I've been in the ER. And, it's not the reality of the situation. It's the exception to the rule. But why does the exception happen? But the exception becomes the pervasive narrative. So when we do think about things like the 988 legislation, which is to have the, easy number versus as your sort of mental health or behavioral health crisis response number, basically the suicide prevention lifeline that's expanded, which is a long number, is now an easy to remember 988 digit. But, we have to ask ourselves, who are the call operators? What biases might they have if they get a call and somebody says, well, there's a Black man outside yelling and screaming and he's running down the street naked. Is it going to get a mobile crisis team, which may include a peer or an EMT or a psychiatrist? It may include a co-responder model, which may be a police officer with another kind of mental health professional. What will it be? We don't know. Yeah. So how do you interact with either the 988 or mental health crisis number? If there are several, I think, in Sacramento, but how are they aware of what it is that Mental Health First is doing so that they can refer to Mental Health First? And then two, how do people get to Mental Health First just at the very beginning, like bypassing everything? I know it's possible. How do they do it?
So we have a direct number Now, 988 is still in the implementation phase, and in the interim, they've just forwarded, right, those calls to the suicide hotline, right, which is definitely great. And a lot of the questions that you posed around, like, so where are these calls going to? I believe that it's going to be, each county is going to be able to set up their own like clearinghouse call centers that field those 988 calls. So Sacramento County, I imagine, will be part of that rubric. But there is a big question mark of how are dispatchers going to be trained? Are we taking those same 911 dispatchers who are going to hear naked Black man and think that they also then need to patch in the police? And when you said that, I thought back to, there was a case, I forget the state, but I'll never forget this man's name. It was Daniel Prude.
Yes.
Yet naked and bagged and still assassinated. Are they going to call the police, right, for someone who is unarmed and not in our shared reality? Or are they going to say, hey, we think that these folks at Mental Health First or somewhere else, right, would be a better fit for that call? We did sponsor and did a lot of work, and big up to James who did the work around the Crisis Act in California. And we hope that the Crisis Act is something that will or can replicate beyond our state, but it allows the state to give funding to community-based organizations to create their own first responder programs. And that's not just limited to mental health, right? There were folks who were in that pool of people that created that bill that were like, well, what about when these like natural disasters happen and folks that are undocumented cannot go to these safe zones? They don't feel safe evacuating with sheriffs or evacuating with EMS because they're undocumented, right? So they were interested in creating like a first responder system that didn't put that population of folks in danger. So I hope that as things like the Crisis Act pass and hopefully replicate, that we can just rethink this whole first response framework. Yeah. Right? Like, how do we have folks that look like us, walk like us, talk like us from our community, but also have the skill set in order to respond to varying crises, or not even crises, even intervention, right? Because there's a lot of folks that do like violence prevention work, and that is very much like a first responder, right? Like when the beef pops off before the guns come out, like who is coming and having those conversations and de-escalating, because we know the police aren't in that business.
Right. And I think this is so important to talk about, because somehow we see some of these things as separate from mental health, but mental health is in everything. So that if you are struggling, if you're, kind of worried about your immigrant status and, there's a hurricane or earthquake and you're not willing to go, not willing, but fearful, rightly so, of being able to get some support that you need, how might that impact your mental health? And what if you have an existing mental health condition? How might that impact? So I think, these are all sort of trauma-based, if you will, sort of kind of responses to things that occur in our communities, but we may see them as separate from mental health, but they are part and parcel of mental health. So if somebody calls mental health first, kind of walk me through exactly what happens. And I know once we talked about the experience where I believe it was an African-American man or African-American, I don't remember, man, woman, use certain terminology that we understand, no code switching, and you were able to support. So let's start from the beginning. What happens when somebody calls, and kind of who answers the phone, and how is all that kind of supporting the person? And if they do need to go to the hospital, how do they get there?
So that story in particular, I think stands out to me because the solution was just so easy. Had he had to use the traditional ways to get transported from where he was to the hospital, he could have been in danger, right? When it was just a matter of a ride. But the term that he used was, I'm not in the mood, right? And as a Black person, right, it's just like, I'm not in the mood means I'm up to here, right? I'm fed up. I'm not having it. And knowing that he was in that space, I can only imagine what would have happened if one of those officers showed up and been like, so how much meth did you smoke today? Blah, blah, right? Instead of like, how can I help you? Or what is it that you need? So we saw that particular issue with just getting him a ride to the hospital. And I imagine that a lot of the things he was not in the mood for, he got a lot of, right, once he actually got into the facility, but at least we were able to help him get there safely.
Yeah, I mean, when you told me that story, I think about the importance of language and understanding language from a cultural perspective, and how, when we're not at our best or we're not in the mood or we've had it up to here, we can use those quote unquote euphemisms, but I will say they're not euphemisms, it's just our language to express how we're feeling, but somebody has to translate that. The beauty of, again, sort of having a diverse workforce is for this very issue, because people might not know what that terminology means and then be able to get to the underlying issue and help do some problem solving. But, you are bringing up another point too about the crisis response is only that. And the crisis system too is only that. There's still the bigger system that a person may be involved in or have to be involved in which the approaches that you're using, which are person-centered, community-based, culturally informed, culturally delivered, by peers, they're not going to get that when they get to the other parts of the system. What kind of backgrounds or training or experience do people have who are doing this work with mental health first to do the work? I mean, are you training them? Do they have other kind of training? Are there also peers, people with lived experience who have had interactions with both police and emergency services and various other systems and services in order to, access and move forward in their recovery?
We don't have any requirements. I mean, except humility. We do ask that folks have some type of lived experience. We have been shockingly surprised, not shockingly, like being a healthcare professional and also like working inside of these very limiting constructs, right? Of what is health, what is healthcare. More and more I'm seeing folks like myself who are like, nah, we got to do something different. This ain't working. We got to do something else, So there are a lot of folks who live in that space who are like healthcare professionals, healthcare workers in some capacity that have volunteered their time. We do train folks. Our training is amazing. It was written by one of our core folks, Chayo, and it really dissects the terms that we use to categorize mental illness, really dissects it, really juxtaposes it to like what medical crisis could look like. And what differs from our training, I would say, from others that are available is at the end of the chapters, it's not like, or call 911. Our sections don't end with that sentence. And then some things that we talk about is like the power in doing nothing, right? Just like being present for that person, ensuring that in that moment there is safety and accepting that like this problem may not be solved in this moment. And that's where some of our follow-up comes in. We have folks that call us like once a week, right? And we sit and we chit chat, and I can only imagine how many times we've prevented those kind of folks from having to be hospitalized, right? Because maybe the real issue is loneliness, right? Prolonged feelings of loneliness can then cause feelings of hopelessness or suicidal ideation, right? And unfortunately, that is a really hard thing to quantify, right? To put into the data envelope and send off to the powers that be to say, see, this works.
So, and my concern about 988 and crisis system reform, this is the first time I'm going to say it publicly. Somebody's heard me use the term once a couple of days ago, but I am going to say it now more publicly on the podcast, is my concern about, because there's such a focus and funding and money on 988 and mental behavioral health or mental health crisis system reform, is that in and of itself is turning into its own industrial complex. And I have such a concern that we are creating a crisis system industrial complex, and it may not benefit, get rid of the may, will not benefit Black and Brown people, because that's not where the focus is. Am I not seeing this? Am I seeing it differently? Am I being too pessimistic?
It's because listen, there's a whole, like, be clear, the industry exists already, right? Like there are whole schools of thought around crisis communication, crisis intervention, how to like manage someone's aggressive behavior, even if like even to the extent of like placing restraints or using our bodies to restrain folks, right? So this school of thought around crisis has long existed. And I think that the investment into managing crisis is a little much. And if we put half of that money into building the infrastructure, then in fact, we might be able to mitigate, right, some of those crises. And I don't know if it's our culture or all this trauma just like reflecting back onto us, but there is something that is much more attractive about crisis, the beginning of that moment, that is much more understandable or tolerable than crisis prevention. I don't know if that makes sense.
Speaking my language, yes.
But it's like we rather invest in that conflict of the crisis than to prevent it.
You know, I'm wondering if it's far more visceral. I was going to put two words together. It's far more visceral and tangible, visceral to people so they can understand it when other things are just not that tangible. Like, you know, when we talk about relational skills and people skills, being able to work in teams, for example, that's called a soft skill, right? So, and it's not tangible, it's a soft skill. It's a soft skill is not important as a hard skill, that really tangible content stuff. So I get this sense that kind of what you're saying, and maybe that's what I'm feeling, is that it becomes sort of this, oh yeah, we get crisis, we get the impact of crisis, and that's maybe easier to resolve in the short term than the prevention stuff that becomes fixing a lot of social ills. And by the way, my big fear too is that mental health gets to hold the bag for fixing all of the social ills.
Honey, I don't know why we can't get to a point where if we're having a housing crisis, why we don't figure out how to get people in houses. I just don't understand for the life of me why we cannot go from point A to point B. Why we got to zigzag our way, right, from a problem to a solution. And I think that you're right. More and more things are going to be thrown under the mental health framework, right? Then need to be. There's this law. California is trying to pass a law that, like, if you turn down a housing resource 3 times, that you can be considered gravely disabled. But we're not talking about whether or not these housing opportunities are sustainable. Like, I'm not gonna go stay in a hotel for 7 days, give up all of my stuff to go do that just to be back on the street a week later. Anyone in their right mind would be like, yo, I'm good. I need something that is more concrete, right? Like more sustainable, long-term even. And there's no question to what these housing services look like. It's just like, if you turn down, 3 hots and a cot, you can't be right in the head.
So I actually had to testify at the joint legislative hearing in California around this very issue of expanding the definition of gravely disabled under LPS, or Latterman-Petrus short. And what was really interesting about that, and I'm pretty sure that people can access it was an all-day hearing, and it was an investigative hearing. It wasn't and here's the bill and let's move it forward. It was much more the health committee and the judicial committee looking at kind of what does this mean, and kind of how, what are we supposed to do about it? And what was striking for me in reading some of the reports was that, once again, yes, mental health carries the burden of fixing housing, employment, all of these things that are in a broad swath, sort of social services. But if somebody doesn't take them, or they're not doing well because they don't have them, it's mental health's fault, and mental health has to fix it. There'll never be enough money. There'll never be enough providers, and that's problematic. Then the other piece, if you listen to the testimony, is around sort of who's accountable to ensure that people have access to these things to begin with, in ways that meet the actual need. Like, are we asking the right question and solving the right problem? Do we understand what is happening to people who are currently under LPS orders, I guess is the right word. And the reality is 50% of the counties are not reporting. So we don't know how these people are doing. We don't know where these people are. We don't know if the programs and services that they're receiving are meeting their needs. Mm. We have no clue. And then for the information where we do have a clue, for the counties that are reporting, they found that there was disproportionality of people who are under LPS orders, if that's the right term, who are Black. Mm. And then we don't know what's happening to 50% of the counties. So where there may also be disproportionality, why would we expand anything? I don't get it. And then when you hear from people, especially during this whole pandemic period, who have been helped in some way by some of the, Project Roomkey and different programs, what people weren't understanding is you could be in Project Roomkey, but you had to change your room every 4 days.
Come on, man.
So it was it's almost like, well, wait, do we understand? I call it the journey map of the people that we're trying to help and support. And we're hitting on something that I hope people take to heart, to ask those tough questions, to look at the underbelly, to look under the iceberg, as I call it, so that we have a clear understanding. I love a lot of like euphemisms, and one of the euphemisms that are sayings, I guess, that was out there is, hey, we're trying to get to people before stage 4, like cancer. Like cancer, there's all this prevention, and we want to have this in mental health. But I think how we've interpreted that is, oh, great, we're at stage 3.7. We are before stage 4, but we're really only at point 3.7.
Right,
really, why aren't we at 0.0 or point, whatever, or we're waiting till people get to the edge of the cliff and capture them right at the edge, or right when they're getting ready to step and fall off, or even maybe when they're falling, versus it took them forever to get to the edge of that cliff. What's happening in that forever space? And then what's happening in that 0 to 3.7 to 4.0, or, falling off the edge of the cliff, being at the edge of the cliff for Black and brown folks? What does that look like? And those to me are questions that are kind of unasked and unanswered. But I, really appreciate first and foremost that, through the Anti-Police Terror Project, that MHF, Mental Health First, was born and kind of brought into this world. I would love to see it scaled.
Right. Us too. And there's folks that have started like programs or started their road, right, to creating a program that were inspired by us. Right. And I feel like that is the dopest thing ever. Even more so than us, like, catching a city contract or something, right? Like, right, like encouraging folks to build independent systems, which is where we are in our course of evolution, specifically in this country. I think more and more folks are understanding that these systems are not made to serve the masses. They are made to serve those who have access to them, right? Because depending on who you are, you could walk into an ER and get a bed immediately, or you can wait 10 hours. It really just depends on, right? Like a lot of the other systems, it's heavily on who you know. And I know lots of stories where even that being Black doesn't really help anyone.
Well, and who wants to be in an ER? I mean, it's just no. And I think that's for anybody. I have a family member who has, a heart condition, and there was a time where it was very clear they needed to be in the hospital. They were in the midst of a heart attack, and they were like, no, I don't want to go. I don't want to bother anybody. Sure. No, I think I'll be okay. It's like, what is the situation like? You need to go. And it was fear. It was loss of control, meaning somebody else is going to be controlling me in a hospital, because that's what happens. And, it was being human, like being human. Who wants to be in a hospital? No one.
Nobody.
And maybe if you do, to me, that might be sort of an interesting kind of, that might be signaling something completely different that we won't get into with this. But, if there's one thing that you want to leave, the folks who listen to the podcast, you're clearly an unapologetically Black unicorn. I think both of us have been like snapping up, thumbs up, clapping around a lot of these issues that you're talking about. But what's one thing that you would like to leave the listeners with?
The boxes aren't real. They're not real. I think that we have to get to a place where we understand that the messages that tell us that we're not enough, the ones that tell us that we're weird, or that no one's listening to you, or that your opinion doesn't matter and that your truth isn't factual. None of that is real. Those are our own thoughts and reflections, right? Being thrown back at us from our conditioning.
Yes.
So you are valid, you are worthy, whatever it is that you are sitting on, right? That keeps coming, do that shit. For me, mental health first is one of those things. It's like, do that shit. And it's getting done, it's being done and replicated. We can have our own systems. Any institution that currently exists started from a few people's crazy idea, whether that be the institution of universities or a fire department or CPS or prisons, right? Like it all came from somebody's idea. We can begin to create our own institutions and sustain those institutions.
Okay, and with that, I am snapping, clapping, head nodding, thumbs up. Amazing. Thank you for spending this time with me. I really, really appreciate it and sharing your wisdom. So thank you so much.
Thank you for having me. It's been an honor to spend this time with you. Thank you.
Okay, and for our listeners, remember to join in to Unapologetically Black Unicorns next week.